We're your FDS shuttle captains. I'm Dr. Elise Everett.
Dr. Everett, we are receiving you. We have beautiful skies and we are all go for our launch of FDS. Hello, everybody. I am Dr. Chris Morosky.
And lastly, I'm Dr. Laura Baker-Lind from cold and snowy Boston.
As we all know, we were supposed to be meeting in Amelia Island right now, but due to the current surge in COVID cases, we had to make a difficult decision to transition to a virtual meeting. Earth has become uninhabitable due to severe climate changes and a pandemic, and we're now coming to you from cyberspace. We'd like to take a moment to thank all of you for being so flexible and working with us as we made last-minute changes to the program over the last 10 days. We're so glad for the opportunity to be together, even if it is virtually, for the APGO FDS. We must also thank the APGO staff for the unimaginable amount of work they have done in the last 2 weeks. We've got a great meeting plan with excellent plenary presentations, workshops, roundtables, and back for a second year, the Innovation Festival. Houston, from cyberspace, APGO 2022 FDS is all systems go.
And before we get started on our journey this morning, I want to give you some tools on how to navigate the virtual meeting platform on Whova. If you haven't already played around with the website, please do so. You can access it through your laptop, through your phone. There's many ways you can access it. The key parts is to look along the column on the left side. Under agenda, there's 2 subcategories, sessions as well as speakers. Sessions is where you'll access the schedule as well as enter any session that you want to participate in. Speaker is where you'll find more thorough bios about all of the wonderful plenary, workshop, innovation station, and roundtable speakers that will be presenting to you at this conference. In the effort to keep everything as streamlined as possible for our cyberspace version of FDS, we have truncated all bios verbally to include just speaker names and their major titles as well as their institutions. But please go into the speakers section to read more about the wonderful speakers that we have for you today. And lastly, under resources towards the bottom of that left column, there's a subheading called documents. It is already chock full of wonderful information, supplemental materials you can take with you back to your institution. So please check out resources and also the document section under there for more information.
And so I'm here to help position your satellites so that you can keep up your communications. For me, the networking and the engagement part of FDS has really been so important to why I come here every single year. I miss seeing everybody in person, but we have multiple ways for everybody to stay connected in our cyberspace virtual environment. So what you want to do is to reach out to your fellow attendees for a direct connection. You can click attendees on the left menu to view people's profiles. And then you can click the say hi button to start a conversation. Real quick way to start a little chat there. Be sure to reach out to connect with those you haven't seen in a while, all right? Reach out to me. My little photo doesn't have my amazing space hat on. A number of topics have been created under the community link to provide a place to connect over the course of the meeting. So if you've got a question, you can post it right in there and you'll get feedback from your peers. And last but not least, you can win fabulous prizes by taking part in our challenges. So click the win a prize link to learn more about fun ways to stay connected during our FDS meeting.
Thank you, Captains Chris and Laura. I can hear you loud and clear. And now we're going to bring in our shuttle commander.
I don't know if Dr. Katz knows that she's been promoted to shuttle commander there, Dr. Everett.
There's the shuttle commander. There was a delay. The satellite was behind a cloud. Okay, so, and now it's my great pleasure to introduce and welcome our shuttle commander and APGO president, Dr. Nadine Katz, to address the group.
Good morning, everyone. Sorry about that. I was busy putting the new title in my CV because you know me, I'm always about career advancement and faculty development. So sorry for that pause. Good morning, everyone, and welcome to APGO FDS 2022. This is going to be an incredible meeting. We already have 133 people on the Zoom, which is great. Thank you all for joining us. Some really super early. Although from Hawaii, no one's going to give you any pity in Hawaii. I first want to start by thanking Molly Georgakis, the executive director for APGO, and the APGO staff for everything that you've done always, and in particular, once the APGO board made the final decision to change this meeting to a virtual meeting. Big decision. We got input from lots of people, just for you to know, not only from the board, but from infectious disease experts, and of course from all the registrants from the meeting with the survey. So we really want to thank you. And then of course, no small challenge for UMEC, because UMEC always says yes. What can we do, and how can we do it even better than you are thinking? So special thank you to Scott Graziano, UMEC chair, and the meeting co-chairs who are on the screen. So that is Dr. Chris Moravsky, Dr. Elise Everett, and Dr. Laura Bacherland. We really could not be doing this without you, and I have every confidence that this is going to be an amazing meeting. The challenge they were given was to, in a very short time, literally in a matter of days, switch everything to virtual and still produce a high quality conference for everyone. And from what I've seen in the planning, it's going to exceed expectations. The APGO network is strong. And if you haven't been on the app, I encourage you to do so. So as I'm speaking, I'm trying not to use the words that were in one of the conversations, which are COVID terms that you hate. So I am trying not to say that we had to pivot, and I'm trying not to say that we had to have yet again another virtual meeting, and I'm trying to not use the word unprecedented and unexpected, and to say that maybe within 2 weeks we'll flatten the curve, and to make sure that you're boosted, not only vaccinated and quarantine and all those other kind of words. And most definitely I'm trying to not say, can you hear me? And can you see what I'm wearing from the waist down, and all those kind of things, and to not have any of those faux pas. But even if we do, it will still be an amazing January FDS because of the amazing APGO members and everyone who has taken the time and made this a priority. And I commend everyone and thank you for being so flexible and understanding as we go into January FDS, but I am really confident that you won't be disappointed. So interact, again, use the really incredible APGO network and networking, and connect with people and learn together. We always do our best when we learn together as the MedEd community. So I'm really looking forward to everything. So while I would have definitely preferred to welcome you in person, I welcome you from my home in New Jersey, where it is quite cold, but I am dreaming, and I know Molly is out there somewhere, I'm dreaming of our next Hawaii meeting, which I know we're trying to put on the calendar to give everyone that lift that we all need. I will be speaking to you again in a couple of weeks. So good morning, thank you, and have a great meeting.
Thank you, Dr. Katz. And we'll see all of you later. We're going to leave you here with Dr. Bacher Lind and our next plenary speaker.
All right. And just another thank you to our shuttle commander leader, Dr. Nadine Katz, who's really steered us well throughout this, this time. And right now I am pleased to announce, to introduce our speaker for our first plenary. We're kicking off with Dr. Megan Evans. Dr. Megan Evans is a general OB-GYN specialist at Tufts University School of Medicine and Tufts Medical Center here in Boston. Dr. Evans is an assistant professor and is also currently the program director for the OB-GYN residency program. She's a specialist also in advocacy and will be speaking with us this morning on becoming an advocacy star, using your voice every day in every way. Thank you, Dr. Evans.
Thank you, Dr. Bacher Lind. All right. Obviously, I wish I could see you all in person. That is what we were all hoping for, but alas, COVID strikes again, and here we are from my attic. So I'm very excited to talk with you about my favorite topic, which is advocacy. I'm going to dive right in because I have a ton to say, and I want to make sure we leave time for questions and conversation. I have no financial disclosures. I am on the APGO Political Action Committee, and also I like to tell people I'm on the Planned Parenthood of Massachusetts Advocacy Board. These are our objectives for the talk this morning. So one thing I always like to drive home is that the people who are introducing legislation, the people who are voting on legislation and inevitably passing legislation are typically not the experts, and especially not the experts in reproductive health and in women's health. And that is why I hope to drive home the point that advocacy is part of our jobs as clinicians, as physicians, and we need to be part of this conversation. This example is a little extreme, but I think especially in this day and age, it really drives home the point of who are making the policies that impact our patients and how we practice medicine. So this is former Ohio State Representative John Becker. He is not a clinician. He is a tax accountant and a utility consultant. And he introduced a bill to prohibit insurance coverage of abortions with 2 exceptions. Now, this is a common thing that we see, especially in certain parts of the country, when trying to limit access to abortion. The first exception was an emergency situation that is medically necessary to save the pregnant woman's life. And second, a procedure for an ectopic pregnancy in which they would remove the ovum from the fallopian tube, for example, and reimplant it in the woman's uterus. Obviously, we know that this is medically impossible, but this is someone who has no expertise, who is writing legislation and introducing it with the hopes of it passing and becoming law. Now, of course, the woman would have to be forced to wait until the ectopic pregnancy became life-threatening. Again, this is an extreme example. This bill did not pass, but again, a concrete example of the people who are introducing this legislation do not have any medical expertise, and especially about reproductive health. We all know what's happening in Texas with the introduction and passage of SB 8 and the ongoing implementation of it. This is Governor Greg Abbott, who signed SB 8 into law. And for those of you, sure everyone knows what it is, but essentially bans all abortions after 6 weeks, and especially after the detection of a fetal heart. So when Governor Abbott was asked about this legislation, he said that it provides people at least 6 weeks to be able to go get an abortion, clearly not understanding that when the person finds out that they're pregnant, they're already 4 weeks pregnant. And that's if they obviously get a pregnancy test at the earliest possible convenience. So again, someone who's passing the most extreme anti-abortion legislation in the country does not understand general reproductive health and how pregnancy is dated. Incredibly dangerous. There's also really well-meaning legislation that's introduced that sometimes misses the mark. And again, it's not always anti-abortion legislation or other legislation that can be harmful. There is positive legislation that we think could have really meaningful impact on our patients that can be introduced, but also may be harmful in some ways. And one example that comes to mind for me is I'm in Massachusetts. there is legislation that's been introduced to have Medicaid pay for doula services. We all think this is incredibly important. We know that this has been shown to reduce morbidity and mortality, especially amongst women of color. However, in this legislation, there's no description of what a doula is and what type of training that the doula needs to undergo. And so someone could easily say, I'm a doula, and then potentially get reimbursed for it. And that could be harmful to some of our patients. So it's making sure that we're paying attention to both positive and negative legislation in regards to women's health and reproductive health. This also is included in not just legislation, but hospital committees, people making decisions about reproductive health without OB-GYNs in the room. I work at a community health center part of my week, and someone decided that the OB-GYNs never needed to use metal speculums, which is a crazy decision for someone who was a dentist who actually will never use a speculum. So it's important that we're at the table and that we're part of these discussions, part of these decisions that are happening about our field. And this is true for our communities as well. School boards are making decisions regarding sexual health education without experts in the room. So we might not be able, unless of course we run for office, might not be able to pass policy or introduce policy or vote on policy, but we can influence it. We do this every day with our patients with specific advocacy. We're advocating for their health care. I've talked to patients about talking to their legislator about cost of prescription medications, other issues that are impacting their care, empowering them to contact their representative as well. Joining a hospital committee, again, bringing yourself to the table, asking to be part of those conversations. I also think in specific parts of the country where there are some hostile environments with regards to reproductive health, sometimes these committees are where we can find our allies. And that's incredibly important. I think about people like anesthesia, radiology, OR staff, when things can get very complicated, and certainly when legislation is impacting how we're practicing medicine. Of course, we can fly to Washington, D.C. We can pick up the phone and talk to our legislators about important legislation that's impacting our field. Social media, incredibly important. I've seen many social media stars in the group here today, and we'll talk a little bit more about the power of social media when it comes to advocacy. And we can run for office. I know that's not always feasible, but I think it's something that many of us should consider. It doesn't have to be at the federal level. It can be at the local level, the state level, but we do need more experts and more clinicians and more physicians in this position of power to help guide and introduce legislation that's really meaningful for specifically reproductive health. This is Representative Lauren Underwood. She is a nurse, and she's a huge advocate for us when it comes to maternal morbidity and mortality, as well as environmental impact on healthcare. I just want to pause for a second, because I know as this was discussed at the very beginning, it's been a crazy years, and I feel like I want to be able to review all the legislation that's kind of happened in this past year that maybe we've missed, and because it's been such a time warp. And I think that it's helpful to go over legislation specifically about reproductive health and what's been happening. And so you know what has been happening behind the scenes while we've been in the clinic seeing patients dealing with COVID. And someone posted this picture the other day, and I could not believe that this meme, it's not even been a year since this picture has been posted. I feel like this was years ago, but it has not even been a year, which is so wild. So let's go through some of the changes and legislation that's happened in the past year. Maternal mortality, an ongoing crisis, no doubt. There are a lot of different ways that we can combat maternal mortality and bring our numbers down. And we know that maternal mortality disproportionately affects women of color, as well as, most importantly, Black women. 3 to 4 times more likely to die of pregnancy-related complications than white women. One way we know that we can work to reduce our rates is by extending coverage of Medicaid to 12 months postpartum. Previously, states could apply for this extension. And I also want to just comment that there are many states that have applied for this 12-month, there are a lot of states that have done Medicaid expansion, which has been incredibly impactful. However, what often happens in these states is that one insurance covers them until 6 weeks postpartum, and then they need to switch to another insurance during that postpartum period to continue that coverage. This is called insurance churn, and a lot of people can fall through the cracks. We know that insurance is incredibly hard to navigate, and this is what can happen in some of those states, even who have extended Medicaid. So it's a long and convoluted process for states to apply for this extension to 12 months postpartum. When the American Rescue Plan passed in early 2021, they included in that a streamlined process for states to extend this coverage much faster than the previous process. This is not a partisan issue. Red and blue states are applying for this because they know this is an impactful way of reducing our maternal mortality, especially when we know that most deaths happen in the postpartum period. The other thing, though, the American Rescue Plan provided is it covered COVID-19 vaccines. It provided additional funding to Title X, a Title X program that was totally slashed under the previous administration. It provided additional funding for GME, something that we're constantly fighting for. And then it also included funding for programs like intimate partner violence, housing insecurity, sex trafficking, things that are very specific to our field. I'm not going to talk about the Build Back Better bill, but that's also an incredibly important piece of legislation for our patients. Not only is it working to have a federal paid family and medical leave, which is critical. We're essentially the only country in the world that doesn't have any sort of paid leave, but also helps with childcare costs, which we know overwhelmingly impact our patients. Mifepristone. So mifepristone, we all know, is a medication that we use to manage medication abortions. It's also used for miscarriage management, although this legislation and policy changes is specific to medication abortion. So mifepristone under the FDA has a REMS criteria. So REMS criteria is specific to medications that have been deemed to be toxic. So for mifepristone, there's 3 criteria: provider certification specific to that medication. The patient has to sign a specific consent form, and it has to be administered in person. So during the global pandemic, obviously it was very difficult for patients to come in to a clinic during a pandemic to try to receive this medication for a medication abortion. It went back and forth through the courts, and after the new administration came into power, the FDA permitted that mifepristone could continue to be mailed during the pandemic, and they were in the ongoing process of reviewing the REMS criteria. Now, it's important to note that there are much more toxic medications that were being able to be mailed without any question, and it was mifepristone that was, for obvious reasons, going back and forth about whether it could be mailed. Fortunately, under this administration, the Biden administration has made this a permanent change that mifepristone can be continued to mail to people's homes for medication abortion. So the in-person administration REMS or criteria is no longer in effect, although the other 2 still are. So a huge advancement. Unfortunately, already 19 states have had a telemedicine abortion, medication abortion ban, and I'm sure we're going to see further advancement of some legislation, both progressive and not. Telemedicine. So telemedicine, big expansion during COVID for obvious reasons, trying to keep patients out of the hospital. So the most important thing is we're getting paid for these services that we're doing. Before, we were calling patients and spending time on them without getting reimbursed for it, and now we have pay parity for telemedicine visits. This has been extended during COVID-19. We're hoping for permanent changes for telemedicine services, and I think that we'll get there. One advocacy goal that I have in places like New England, and I'm sure many of you can relate to this, is I would love to have an ability to apply for a multi-state medical license so that I can have a license in New Hampshire, for example. So my patients who come down and see me in Boston, I can do a telemedicine service and still have it covered without having them to drive into the city or cross the border in order to get telemedicine services. Reimbursement. Reimbursement is a complicated topic. I'm going to try to make it as simple as possible. At the beginning of 2021, CMS increased payment rates for E&M codes. I think we all know that. But initially, they were not going to increase global obstetric codes, and the rate was actually going to go down. We know that this has such negative impacts on especially rural communities. When they're losing money for obstetric care, maternity wards close, access changes. So this was corrected with a lot of advocacy. But we're going to see more cuts coming down the road for Medicare services. So this just passed in mid-December by President Biden signed it, but we just kicked it down the road again. Medicare, there's a thing called sequestration. And Medicare, because of our increased deficit, we take money from Medicare. So there was going to be a 2% cut. There's now going to be a 1% cut in April 2022. Additionally, that American Rescue Plan bill that I talked about earlier has PAYGO, which is pay as you go. This is going to impact physicians and facilities as well. So a 3.75 cut to physician reimbursement who accept Medicare, and more cuts to facilities. This has now been delayed until 2023. And I know it's always hard to talk about reimbursement when it comes to advocacy and clinicians, but this impacts our patients. I don't so much think of it as like lining our pockets. That's not what we think about, but it impacts whether facilities can provide Medicare services, can see those patients. And most of the patients we see who have Medicare are either under a disability or are older and are for cancer care. And so this is something that we're going to be continuing to deal with in the next couple of years. COVID-19, I'm sure everyone is so tired of talking about COVID-19, especially with vaccines. And I know that we advocate every single day for our patients to get vaccinated. We know that there's higher rates of death, intubation, complications when our pregnant patients get COVID. And so I won't spend a lot of time on this because I'm sure you're all tired of it, but the advocacy around this has been so critical, and especially coming from trusted sources when there's so much misinformation out there. ACOG, SMFM, each of you who spend time to advocate on these important issues. Something that I don't think we talk as much as we should about is climate change and maternal morbidity and mortality. We're obviously seeing a lot of climate change happening around the country. And we know, again, that these climate changes disproportionately impact women of color, communities of color, low-income people. This is only going to get worse, and it's something that we need to continue to address. Representative Lauren Underwood, who I mentioned earlier, has introduced legislation that directly talks about environmental changes and how to combat that, especially in urban communities where we do see rising rates of temperature within those communities. And then also trying to ban really toxic chemicals that are endocrine disruptors that have harmful impacts during pregnancy. So this is something that continuing to focus on. Abortion access, obviously a huge issue. 2021 is already looking like the worst legislative year for US abortion rights. We know Texas SB 8 still in play, unfortunately, not a lot of legislative changes, huge impact on our patients. Patients having to travel to 11 different states to get abortion services outside of Texas. And the important thing with SB 8 is that it doesn't make abortion specific for people seeking abortion. It makes pregnancy dangerous because providers are having to question whether they can provide a service that they know is the right thing to do because of legal ramifications. The Supreme Court case was just heard on December 1st, Dobbs v. Jackson out of Mississippi, which is a 15-week abortion ban. This case, I think many of you who are following this has the potential to change what abortion looks like in the United States. I think a lot of concern that Roe could fall after the hearing of this case, and especially the makeup of the Supreme Court. So a lot of concern around this. And I think this goes without saying that if Roe falls, these 26 states are very certain to ban abortion. And you can see the makeup of what this will look like in the country. And it's, you know, what the concerning thing is a lot of the states that are highlighted orange are also the same states that have the highest maternal mortality and morbidity, the highest neonatal morbidity and mortality. And, you know, I think this is definitely going to change who is going to apply to our residency program, who is coming and who is not coming. This is going to be, depending on the decision, a huge impact for our field, no doubt. There is a legislation called the Women's Health Protection Act. This was introduced in Congress. It would basically make it so that any unnecessary restrictions would be eliminated. If it would be passed at the federal level, it would negate anything that happened at the state level. This was passed out of Congress favorably. It is in the Senate. It will likely not pass the Senate, unfortunately. So that very quick and whirlwind of a wrap up. But what do we do about it, and what can we do about it? And many of our colleagues have been very active, writing op-eds, being on social media, testifying, and sending emails, doing advocacy every single day, giving presentations. And so we're going to talk about how can we incorporate advocacy every day. For me, and I know I can't speak for everyone, but advocacy for me is part of my wellness. It reminds me of why I went into OB-GYN. It reminds me of why I care so deeply about these issues and how I can use my voice as a clinician, as a trusted member of the community to try to make meaningful changes. So one thing I think is very simple is signing up for advocacy newsletters, getting an email in your inbox, being able to, within seconds, send an email to your legislator, asking them to consider this legislation, not consider this legislation. This takes minutes. And I know a lot of people feel like it doesn't really matter, me sending an email. It does matter, because you can imagine at the end of the day, when your senator gets back to their office and they ask, what are you hearing from the constituents? And they say, well, we got 200 emails today from this physician group in support of this legislation and only 10 opposed. That matters. They're paying attention to that. So your one email does make a difference. And it's such a simple way to incorporate advocacy into your daily life. ACOG, it's simple, super simple to subscribe to the advocacy newsletter, but other organizations similarly will have action alerts where you can easily sign up and send emails to your representatives. Calling your representative. I know this can be intimidating for people, but I promise you it is not intimidating. You are the expert. And I never want to hear, especially medical students, residents, even in attending, say, well, I'm just an OB-GYN in this community. I'm just a medical student. As I have shown, you have more medical expertise than the people who are introducing the policies and voting on legislation that's going to impact our patients in our field. It's so simple. And you know, my ultimate goal, and I feel like your ultimate goal too, is your state representative, whenever a reproductive health legislation comes up, your face should pop into their brain. I should contact Dr. Evans and see what she thinks about this legislation. That's the goal, right? We want to be the trusted source that our representatives go to. I have a friend who, she always calls her representative on the way home from work. Their office isn't open. She leaves a voicemail and talks about why they should consider this legislation or not consider this legislation. So taking to social media. Again, I think social media for some people can be intimidating, but it's such a powerful tool for advocacy. If you think about your emailing your representative, the only people that see that email are you and the representative and their staff. Where if you tweet at them, you're elevating that message to such a higher platform. People retweet it, they look at the hashtag, all of a sudden the hashtag's trending. They discover what's happening with reproductive health. When we eventually, hopefully we'll be meeting in person at the CLC next year, but we're constantly trending when we're in DC with CLC, and that really elevates our message and really elevates our advocacy efforts. And in the workshop that we're doing after this, we're going to talk about social media and ways that we can be more active and especially more advocacy active on social media. These are two people that I follow on Instagram that are both OB-GYNs that do a really incredible job on the Instagram platform with videos, different advocacy efforts, and talking about complicated issues in such a meaningful and respected way. And I think that if you're looking to get on Instagram, these are great people to follow who've done a really incredible job. So again, joining a hospital committee. I know we're all busy, but again, this is where we can make meaningful changes for reproductive health, OB-GYNs. We don't want people to make decisions without us at the table. And if no one invited you to be on that committee, you know, email them up and ask if you can join, because these are where those changes that drive us crazy in the clinic can happen, and also where you can form those important allies, especially in more hostile environments. Write a letter to the editor and op-ed. This also is not for everyone, but I think that once we break it down, it's always not as intimidating as you think. A letter to the editor is typically between 200 and 250 words. Many local newspapers publish every letter to the editor. And so I'm always surprised as how many people watch local news and how many people read their local newspaper. So if there's a topic that you want someone to know about, Medicaid expansion, maternal mortality, environmental changes, this is a great way to talk to the lay community about important issues that you want them to know about. An op-ed or a column, typically 750 to 800 words. It's, you know, I know we always say about New York Times, your like Boston Globe, Washington Post, that's not your goal, right? You want to get it in a place where it's going to get published and you're going to get a lot of readership. And this is also something we'll be breaking down in the workshop as well. Research and opinion pieces. I know a lot of you in academics are doing research. You can use your research and advocacy efforts. And this is something where especially perspective pieces are often published without needing a membership to that journal or a subscription to that journal. And this can be shared widely in a vast amount of different audiences. One of our residents wrote about her own experiences being Asian American. This is something that can be shared in a vast amount of different communities. Myself and Dr. Farrell out of Beth Israel wrote about extending Medicaid for 12 months postpartum. We published it in a medical journal, but we've shared it with policymakers and legislators to talk about why this legislation is so important. Many of us get OB-Gyn management, contemporary OB-GYN. There's a lot of different online platforms that are catered toward the medical community, a great place to talk about different advocacy efforts. And what I tell my residents is, you know, if there's something that you want to share or there's something you want to do, email the organization, email the group. The worst that they're going to say is, no, we're not interested in that topic right now. But oftentimes they are interested, especially with some of the issues that happen in reproductive health, and especially now. And this is a great platform to not only talk to other clinicians, but essentially, potentially other lay people as well. You share it on social media. Again, you elevate that platform. You talk about those issues. Testimony. So written or oral testimony. This is also something we'll be talking about in the workshop. Showing up to testify for or against legislation is incredibly powerful because the people know that you're a clinician. You've taken time from your day to come and advocate for this legislation. It's hard though. Oral testimony is unpredictable. You have to wait a while, but it's so meaningful. And we also talk about how to break this down because testifying is not as intimidating as you think. Again, you are the expert. You can always submit written testimony, which again is very powerful. You took the time to write written testimony. For those of you who are involved in your state legislative group, this is often something that we do pretty routinely, is submit written testimony. And then some of us will come and give oral testimony for or against specific legislation. You could run for office. This is Dr. Kristen Lyerly. She ran for state assembly in Wisconsin. We need more clinicians and physicians in office. There's no doubt about that. And there are a ton of resources for physicians who want to run for office. Dr. Kristen Lyerly did not win her race. She came very close, but now she's so ingrained in Wisconsin politics that she's making such huge impacts on different aspects of the political realm within Wisconsin. And I think she's going to be a huge star in the future with all of this. Training and advocacy. So, you know, at Tufts, we strongly believe that advocacy is part of medical education. It is part of our jobs as OB-GYNs to advocate for our patients. It's also a CREOG objective. So it is required in residency training to teach an advocacy. So this is something that we've talked about for years about ensuring that our residents graduate with the confidence and the tools to be able to advocate for their patients. I always remind people that you cannot be a good advocate if you're not a good doctor. And so that That's our #1 priority in residency training, but advocacy is also part of being a good doctor and continuing to advocate for your patients after you graduate from residency. During the pandemic, when things were a little crazy, a group of us felt that there was a piece missing in OB-GYN advocacy, and we started a podcast, and we bring on really incredible speakers to talk about important issues that we think that OB-GYNs and the general community should be aware of. This is the 4 of us. We're all in different parts of the country. We all have different interests and backgrounds. And if this is something of interest to you, you can listen on your way to work. It's something that we've had a lot of fun with, and I think that will continue to evolve as certain issues come up in our field. And if you want to join us on the podcast, send me a message. Donating to a PAC, so a PAC is a political action committee. I think that some people feel uncomfortable donating to political candidates. The way that I feel about it is that, again, these are the folks who are going to introduce legislation that's going to make meaningful change in our community. So by donating and involving myself in their campaign, I am investing in my community. And we have a very robust PAC here at APGO. And so if it's something that you're interested in, or if you want to ask the PAC to donate to a candidate that you're interested in, you can also do that. And I'm happy to talk with you offline about how to do that as well. And lastly, vote. We cannot make meaningful legislative changes without voting. And especially as leaders in education, we should be setting a priority for our residents, our medical students, our faculty to vote. Of course, early voting is important, but it should never be like, sorry, we don't have time for you to go vote. That's not the right message to be sending to our residents. Voting is a priority, and we should continue to promote it. And not just the main elections, the primaries, the local elections, all of these races, as we know, matter so incredibly. You're not alone though. So I know I've given you a ton of things that are potential for advocacy efforts. You're never alone in these efforts. You never have to sit down and think about writing that testimony by yourself, writing that op-ed without someone reviewing it. There's so many resources at our fingertips. Our legislative committee, our medical society, and especially APGO government affairs and state affairs. They are a wealth of knowledge and information, and the communications department usually gets back with you within 24 hours if you want them to review your op-ed, if you want them to go over meeting with media. All of these things are at your fingertips and are resources for you. And of course, the patient is at the center of everything we do with advocacy. I do think that statistics are important. We talk a lot about statistics, but really at the end of the day, it's the patient stories that we bring with us when we send that tweet, when we send that email, when we meet with our legislator. That is at the core of all of our advocacy efforts. In the last bit of time that we have here, I wanted to give you some case studies of some advocacy efforts, just so to put things into perspective, give it a little bit more tangible of what is possible with some of these daily things that you can incorporate to be an advocacy star. One of my main interests is the Medicaid sterilization consent form. I know you are all very familiar with it. And what we found in Massachusetts and in some of our research around the country is that there's a lot of misinformation and misnomers about this form. Myself and Dr. Nina Kaspa out of Bay State, we decided to work directly with Mass Health, which is our Medicaid organization in Massachusetts, to make a step-by-step guide for clinicians so that they understand exactly where the errors occur and how to fill out the form. We found that there was a lot of myths around this form, that if the form wasn't filled out correctly, they would not get reimbursed for the entire pregnancy. That is a myth. And that's what we were trying to combat, to make sure that our patients received the contraception that they wanted. So this is something that we've worked at the state level. We're hoping to take it to the federal level in hopes of making it more streamlined across the country. So remember our example from the beginning. So one brilliant advocacy move that I found was Dr. Daniel Grossman wrote an opinion piece, not in San Francisco where he's based, but in Ohio. He published an opinion piece about this legislation in the home state where the patients that were going to be impacted live. And I thought this was such a brilliant advocacy move, because the people in San Francisco where he could potentially publish, it doesn't impact them. It impacts the patients in this community. So a great advocacy example. In Massachusetts, we had a very big legislative success with the Roe Act, which further codified abortion access in Massachusetts, and we're able to now offer terminations for lethal fetal anomalies. We also have a parental consent law that was below for minors. It's now changed to 15 and younger, so 16, 17-year-olds can consent for their abortions. And one critical component of being able to do that was a research study that came out of Brigham and Women's, looking at how much more patients were delayed in getting their abortions by this judicial bypass and by this parental consent law. So again, using research to impact legislation, such a great example. And it really made such a difference when we were there testifying in favor of the Roe Act. So again, showing up for state lobby days, advocacy days, showing up to testify, so impactful. This picture on the right is an MFM, a resident, myself who's a generalist, and a family medicine doctor, all from different backgrounds. We all had different aspects. We were organized. I was 36 weeks pregnant, and it was so an interesting time to advocate for this legislation. And of course, this is all pre-COVID when we were able to meet in person. But these state advocacy days, if you're able to go, or if you're able to send your residents, so impactful. We know that some of the most progressive and some of the most harmful legislations are happening at the state level. So we need to show up for those legislations and show up to talk to our legislators about the importance of this, what the impact could be. This is my friend's research study, Dr. Dayton Nicola. He does a lot of research on air pollution and the impact on pregnancy. Again, this type of research has been very impactful on what has been introduced in Congress. So under Congresswoman Lauren Underwood's legislation directly revolved around this research study. So again, our research can serve as a vector for advocacy. Social media, like I talked about in the beginning, with social media, sending an email. So if I were to send an email to Congressman Frank Pallone, thanking him for meeting with us about passing the Preventing Maternal Deaths Act, I see that email, he sees that email, nobody else. But if we send a tweet and we tag him in it and it's retweeted, that message is elevated. It puts pressure on him to pass this really important legislation combating maternal mortality. And this is, again, when we go to the State House, when we meet with our representatives, when we want our representatives to pay attention to certain issues, an email, yes, is important, but so is elevating that platform with things like social media. This is one of my former residents. She's now a Gynecology fellow at MD Anderson, but she's from Juneau, Alaska. And when Title X was changed under the prior administration, and really prevented physicians from counseling for all different options, she wrote an op-ed in her hometown of Juneau, Alaska, not in Boston, Massachusetts. Again, such a brilliant move to try to bring advocacy to her home community, where it's going to impact patients in a different way than it would in Massachusetts. When Congresswoman Ayanna Pressley was running for office, I got involved in her campaign because I thought she was such a force. I asked ACOG and submitted requests for ACOG, or the PAC, excuse me, to donate to her campaign. We donated to her campaign, and now she's a huge ally with ACOG. She is incredibly involved in maternal mortality. She has been involved in reproductive health access. This is a champion that we have, and now we're strengthened with her because of our PAC involvement. So again, involving with political figures. And of course, this is at the CLC when we could meet in person. What a beautiful picture. There's 700 OBGYNs that flew in from all over the country. And here's me. So yes, I am just one person, and maybe I will send one email or I'll send one tweet. But if you imagine if all of these other people, when we're all together, virtually or not, are doing that as well, how much of an impact we can make. So never think that your one email, your one action isn't meaningful. It is. And especially when we're all doing it together, you can imagine the impact that we can make as clinicians for our patients. Lastly, we cannot be good doctors, we cannot be good advocates if we're not well and if we're not taking care of ourselves. There are days when I am rocketing that advocacy all over the place, where I'm sending tweets, I'm sending emails, I'm working on action alerts. And there's days that I can't do it. I can't listen to the news. I need to go home and be with my family, and that's okay. That is how we keep going. That is how we stay well. And I know, especially in the last 2 years when it's been especially overwhelming, I hope that we all take time to recharge, and so we can be the best advocates and the best clinicians that we can be. Unless someone like you cares a whole lot, nothing is going to get better. It's not. This is from the Lorax, a perfect quote to end with. Again, I strongly believe, and I hope you do too, that this is part of our job. This is part of our career. We have to continue to advocate for our patients, no matter how big or how small. It makes a difference. We have to show up for our patients. We have to show up for our community. And I hope that through this talk, you've found meaningful ways that you can incorporate advocacy into your daily life and be an advocacy star. So I want to thank you so much for your time. This is my handle on Twitter, and I hope we connect there. And I'm happy to take any questions.
Okay, thank you so much, Dr. Evans. That was a fantastic start to the FDS 2022. And I really thoroughly enjoyed the idea of this fueling your tank, of this being your source of wellness, and giving us some tangible impacts that advocacy has had for our field and for our patients. There's a lot of fantastic comments coming through the chat. I have a few questions for you as well. One of the first questions comes from Dr. Schaefer from Ohio. And he asks, what if you know your representative or senator is a dyed-in-the-wool conservative who will turn a deaf ear to your plea? Is it futile to reach out or to send letters?
Yeah, I think that's a great question. And I strongly believe that you can't approach every advocacy effort the same. And I think that, for someone like that, where you're not going to really get in the door with certain issues, I think that this is the long game. And I think that for someone like this, you find something that you have a common interest in. And most often I find that many people are not excited about the maternal mortality rate. And this is where you can start to build a relationship with that senator. You may not be able to change their mind on other issues like abortion, but developing a relationship over time, that's where you can at least get to the table and have those conversations. I think that you have to be thoughtful about what issues you talk to them about, but I don't think that it's futile. I think that if they see more and more constituents are caring about that issue, yeah, you may not turn that person into progressive or liberal, but you may give them pause about certain legislation that they vote on. And especially if you develop a relationship with that senator, they may reach out to you about specific issues. So it's certainly in those situations, I think, more of the long game.
Mm-hmm. Yes. And building those bridges is so important, especially in this world. A question from Dr. Katz. Thank you for your excellent talk on this important topic. Can you please comment on any ways to help get advocacy specifically on OB-GYN issues into the curriculum? Are there any curricula out there that you're aware of that people who are at institutions that don't have already a strong advocacy curriculum can easily incorporate into their program?
Yeah, so we have an advocacy curriculum that we'd be happy to share the outline with people. So we do kind of a basic advocacy 101 of what that means, what that could look like. Also different tools and it was made by Dr. Prithanandi, who will be joining me for the workshop. There's also a couple years ago when I was on the Junior Fellow Congress Advisory Council, advocacy was a big part of our push. And we made a bunch of different modules that are available, I believe, on the APGO CREOG website that people can utilize. So you don't have to reinvent the wheel. We typically do 5 to 6 talks a year. You could do less, you could do more, where you're having either guest speakers or you're using the modules that are made. journal clubs, PowerPoint presentations that are already done, and different modules that you can do. So certainly I'm happy to provide that link if needed.
Perfect. And we can place that in the resources folder that I mentioned earlier that's on Whova. Thank you. Another question that came in is from Dr. Morgan in Michigan. She asks that about medical students. So medical students are often so interested in advocacy, and we're always interested in recruit the best and brightest medical students into our field. Do you have any suggestions for tactics to help recruit early medical students into advocacy work?
Yeah, I think, oftentimes I feel like medical students come to us, which is always great. I think probably the best way with medical students is to coordinate with their OB-GYN interest group and talk about ways that we can advocate in OB-GYN. With APGO, I know medical students can become free members, and so that they can get those advocacy alerts as well. We always have within our Massachusetts APGO Society, have medical students come if they want to different meetings and different on our legislative committee as well, which is a great way for them to get involved. But I think connecting with the OB-GYN interest group is a really wonderful way to get started.
Okay, perfect. And there's a question here from Dr. Pollack. She's requesting clarification as far as where dues go for APGO versus for the Political Action Committee. Do you have joint membership in both automatically? And is trying to figure out how to navigate that to make sure that she's involved in the Political Action Committee.
Yeah, so it is separate. So your dues do not automatically go to the Political Action Committee. You would donate separately. I think when people reinstate their membership, there is an option to donate to the PAC, but it is kept separate. But we have, unfortunately, because we're not in person, we have such fun PAC events, but you can still do virtual PAC events. And if there's a candidate that you're really excited about, you should definitely apply to see if the PAC can fund that candidate. It's always a great way to connect with candidates early on when they're running for office. The PAC I think there's a separate website that I can try to find for people to look into the PAC and who we've given to in the past. It is a bipartisan PAC, and we cannot pass anything legislatively without having both Democrats and Republicans and independents voting for it. But yeah, they are separate.
Great, thank you. And there's a question I'm seeing also that's in the chat section from Dr. Abbott. Dr. Abbott asks, how can we raise our voices most effectively to advocate for funding for other members of the OB care team, such as nurse midwives, PAs, doulas? Are there ground rules or controversies on how to advocate for these other members of our team?
Yeah, great question. APGO, I think, has long had a very positive relationship with midwives and some of our, mostly midwives, I think, with the National Midwife Organization. So there's great resources on the APGO website. I think that using your platform, just like we talked about with social media, collaborating with different fields, and maybe writing a letter to the editor or an op-ed with a nurse practitioner, with a midwife. I think that's something that you could even consider in these places like Massachusetts, where we're looking at the doula bill. This would impact all of our patients, including those who care for OB patients in the clinic. So, nurse practitioners, PAs, midwives, a really good conglomeration. And that's a great way to bring someone along for your advocacy effort. Like, hey, I'm looking at this. Let's go to the State House together as a midwife and a physician to advocate for this. So really bringing them along and asking them to come with you on your advocacy efforts.
Perfect. And I think we're down to maybe one last question that I'm seeing here. There is a request, Dr. Evans, do you happen to have a map that does overlap both the potential states that will restrict abortion services if Roe v. Wade gets banned versus, and that directly compares it with the maternal mortality data?
I don't personally have it, but I definitely have seen them. I think the resources that I typically go to for information like that are Guttmacher, and then Kaiser. The kff.org website has a ton of resources about not only abortion access, but maternal mortality as well.
Great. And there's also a number of comments, resources that are popping up in the chat. We'll do our very best to make sure those get also uploaded. I know Dr. Nandi has posted some that you were referencing, Dr. Evans, and we'll get those into the resources tab, again, in the documents section. So stay tuned and check that section out later. So I just want to thank Dr. Evans again for a really fantastic plenary talk. I think we were all very inspired, learned a lot, and I have a feeling there are going to be many representatives across the country that are getting texted, emailed, and tweeted at throughout the weekend. So thank you again for joining us this Sunday morning. And to all the participants out there, please make sure that you go to the agenda section on Whova and register for the workshop that you're planning to attend. That will be starting at 11:15 Eastern Standard Time. So please join through that agenda section and then the sessions subsection and register for that there. We will meet at 11:15 for the workshops. In the meantime, please take a break, stretch, and grab a snack. Thank you for joining us.